Good day and welcome to this installment of the Gross Anatomy video podcast series. This is Dr. Stuart Ingalls. We continue our journey through the lower limb with a look at the gluteal region, posterior compartment of the thigh, and a look at the knee joint. Objectives for today's lesson. First, we'll consider the gluteal region, paying particular attention to the actions of certain muscles we find in this region and the orientation of neurovascular structures in relation to certain foramina and muscles. Second, we move into the posterior compartment of the thigh, looking at muscle action and the course of some neurovascular structures through this region. Next, we'll take a particularly focused look at the knee and some of the more common pathologies we see here. We'll also take a few minutes to consider surface anatomy in this general area. The gluteal region consists of the pelvic girdle of bones and the associated muscles. It represents a transition area between the trunk and the lower limb, similar to the shoulder region for the upper limb. Anatomically, it is still considered part of the trunk, but the muscles in this region all act upon the femur across the hip. The posterior compartment of the thigh is the third and final compartment we need to discuss. It is primarily responsible for extension of the hip and flexion at the knee. It's innervated by the sciatic nerve, which itself is actually a combination of two mutually exclusive nerves, and its vascular supply is from the profunda femoris via a series of perforating branches, which we discussed in the previous lesson. We'll begin with a look at the sacroiliac joint. In our previous lesson, we mentioned the uneven auricular surface on the ilium that limits motion at the sacroiliac joint. It might seem a little strange to have a joint here at all when you consider the complete fusion seen with the os coxae, but a patent sacroiliac joint seems to have a beneficial role in shock absorption from ground reaction forces during walking and running to resist a pelvic fracture. For an immovable joint, though, it has a rather complex structure. There are actually two distinct parts to this joint. Anteriorly, we see the synovial joint portion between the articulating surfaces on the ilium and the sacrum. Posteriorly, we see a syndesmosis, which is a specialized type of joint in which bone tuberosities are connected through thick ligaments with an absence of a true joint space. Movement is highly restrictive at syndesmoses, which serves to reinforce the sacroiliac joint, protecting it from injury. We want to minimize movement at the sacroiliac joint as much as possible, so the sacroiliac joint is greatly reinforced through a series of both intrinsic and extrinsic ligamentous attachments. Between the posterior tuberosities are deep interosseous ligaments that directly bind both surfaces. These are continuous with the posterior sacroiliac ligaments that provide additional reinforcement. Similarly, the anterior synovial joint is reinforced by thickenings of the synovial joint capsule, the anterior sacroiliac, and the iliolumbar ligaments. Two additional extracapular ligaments provide further support by preventing anterior rotation of the sacrum on the ilium. The sacrospinous ligament runs from the lateral border of the sacrum to the ischial spine, while the sacrotuberous ligament runs from the posterior surface of the sacrum, where it blends with the posterior sacroiliac ligaments, to the ischial tuberosity, blending with the common hamstring origin. This lateral view will give us a better understanding of the role of the sacrospinous and tuberous ligaments. Notice that the fifth lumbar vertebrae, and hence the axial load that runs through it, is located anteriorly to the general position of the sacroiliac joints, approximated by this oval. This would have a tendency to rotate the sacrum anteriorly relative to the ilium. The sacrospinous and tuberous ligaments anchor the posterior aspect of the sacrum to the inferior aspect of the pelvis to provide resistance to this rotational force. We can now look at the muscles of the gluteal region. The region can be divided into superficial and deep compartments. We'll start with the superficial gluteal muscles. The most prominent muscle in the gluteal region, which also happens to be the thickest muscle in the body, is the aptly named gluteus maximus. It has an incredibly broad origin off the lateral aspect of the sacrum and the medial aspect of the ilium, bordered by the posterior gluteal line and the sacrotuberous ligament. The fibers that project infralaterally to insert on the iliotibial band from posteriorly. This insertion continues to extend inferiorly to the gluteal tuberosity on the posterior aspect of the femur. The gluteus maximus contracts to generate a rather forceful extension of the hip joint from a flexed joint position, such as rising from a chair or climbing upstairs. The muscle shows minimal activation while walking on a level surface, however. In this situation, we place greater reliance on the hip extensors in the posterior compartment of the thigh. This muscle is also a powerful external rotator of the hip. Gluteus maximus is supplied by the inferior neurovascular bundle. Deep to gluteus maximus is gluteus medius. It originates off the outer surface of the ilium between the posterior and anterior gluteal lines. The muscle then inserts on the posterior aspect of the greater trochanter. It's supplied by the superior gluteal neurovascular bundle. The action of gluteus medius can be a bit confusing based on the two-dimensional pictures in your book. From the posterior view, one gets the impression that gluteus medius may be an extensor and lateral rotator of the thigh. In reality, because of the way that it wraps anterior to the hip joint, it's actually an abductor of the hip as well as a medial rotator. You can verify this by standing and palpating the fleshy material posterior and slightly superior to the anterior superior iliac spine. Now with your feet planted, try to inwardly rotate at the hips to try and make yourself go pigeon-toed. If you do this properly, you should feel the muscle mass bulge under your hand. That's your gluteus medius muscle. Deep to the gluteus medius is the gluteus minimus muscle. It originates off the gluteal surface of the ilium, inferior to the inferior gluteal lines, to insert on the anterior aspect of the greater trochanter. Like the gluteus medius, it's also supplied by the superior gluteal neurovascular bundle and aids in abduction and internal rotation at the hip. We normally speak of the abduction properties of the gluteus medius and minimus, but in instances where the foot is planted in a one-legged stance, the gluteus medius and minimus are involved in leveling out the pelvis relative to the ground. In a two-legged stance, the axial load is evenly distributed between both legs, as discussed in yesterday's lesson. In a one-legged stance, on the other hand, the unsupported side has a tendency to tilt due to the fulcrum generated at the supporting hip. To correct this, the gluteus medius and minimus contract to pull the pelvic girdle back into alignment. It's still the same action on the joint, but with a different appearance, having the foot planted. This is the principal role of this set of muscles, as it allows for proper clearance of the unsupported limb during the swing-through phase of normal gait. Damage to the superior gluteal nerve or muscle pain compromises the action of these muscles in the stance leg, and the hip pushes out dramatically to the side during gait to compensate for the pelvic sag. Sort of resembles the hip swagger used by runway models. Alternatively, the patient may shift their center of balance over the affected support leg to compensate for this loss. These presentations are collectively known as Trendelenburg's sign and is indicative of neuromuscular dysfunction in the support leg, in this case on the individual's left-hand side. Another important clinical note for gluteus medius and minimus is their role in intramuscular injections. The gluteal region is an ideal injection site due to the thickness of the muscle tissue for absorption of the medication, but care must be taken to avoid certain neurovascular structures that can be damaged by an improperly placed needle, which is complicated by normal interpatient variability. A safe region has been identified that presents a low risk of neurovascular damage. The physician places the palm over the greater trochanter with the index finger directed towards the anterior superior iliac spine and the middle finger directed towards the tubercle on the iliac crest. The region in green is generally considered safe for performing these intramuscular injections. The next muscle on our list for identification is the piriformis. Piriformis is a Latin term to describe the shape of a pear. While we'll only see the narrow insertion of the piriformis in lab initially, it broadens like a pear as it projects through the greater sciatic foramen and approaches its origin off the internal surface of the sacrum. The muscle inserts on the greater trochanter medial to the insertion of gluteus medius and minimus and serves as a lateral rotator of the hip. As we will later discuss, piriformis is an important landmark for several neurovascular structures. We can now look at the deeper muscles in the gluteal region. First is the obturator internus, which, as the name implies, originates off the internal surface of the obturator foramen and membrane. The muscle winds posteriorly and takes a 90-degree turn to project laterally to insert into the trochanteric fossa along with obturator externus. On its path, it's joined by two additional muscles, the superior and inferior gemelles, or twin muscles, which originate off the ischial spine and tuberosity superior and inferior to the tendon for obturator internus. The last muscle in this group is the quadratus femoris, which originates off the furrow between the ischial tuberosity and acetabular fossa to insert between the greater and lesser trochanters. Collectively, these muscles combine with piriformis to help laterally rotate the hip. In addition to their obvious role in movement of the femur, the muscles of the gluteal region also serve as important landmarks in identifying important neurovascular components within the gluteal region. Of particular importance is the piriformis muscle, which exits through the greater sciatic foramen. The superior and inferior borders of this muscle normally mark the boundaries for a number of important neurovascular structures. Superior to piriformis, we observe the superior gluteal nerve and vessels. As previously mentioned, these supply the gluteus medius, minimus, and tensor fascia lata muscles. This is distinguished from the inferior gluteal nerve and vessels that supply the gluteus maximus muscle. Several other neurovascular structures emerge inferior to the piriformis. Probably the most distinct is the sciatic nerve, which projects inferior to enter the posterior compartment of the thigh. Although the sciatic nerve is one of the most clinically relevant nerves in the body due to its role in back pain, it's actually not a distinct nerve, but rather a combination of two smaller and distinct nerves that are bundled together as they pass through the gluteal region and posterior compartment. Imagine wrapping your index and middle finger together in athletic tape and you'll get the idea. The components of the sciatic nerve course through the posterior compartment of the thigh and branch to supply all compartments of the lower leg. We'll return to this structure numerous times over the next few lessons. Medial to the sciatic nerve is the posterior femoral cutaneous nerve. Although it is strictly a superficial nerve branch, it is quite distinctive due to its relatively large size. Further medial, we find the pudendal nerve and internal pudendal artery, which course out through the greater sciatic foramen and back into the lesser sciatic foramen, where they run through an expanse of fascia projecting from the obturator internus called the pudendal canal. This is the neurovascular structure to the perineum or pelvic floor and will be revisited in the final unit of the course. In addition, we also see two small nerves branching directly from the sacral plexus. These are the nerve to obturator internus, which also supplies the superior gemellus, and the nerve to quadratus femoris, which also supplies the inferior gemellus. The mnemonic PINS is often used to identify these structures from medial into lateral in the pudendal canal. This brings us to the posterior compartment of the thigh, which we alluded to in the previous lesson. We find three separate muscles in the posterior compartment, one with two very distinct heads. Three of the muscle bellies originate off the ischial tuberosity and can be palpated during the act of standing from a seated position. This is collectively referred to as the hamstring muscle group. The name's a little barbaric, actually. It stems from a butcher shop. When pigs were slaughtered, the thigh was opened up and this tendon severed to string the animal up in the smokehouse. The three muscles share a common function as well as a common innervation. Two of the muscles insert medially, while the bicipital muscle fuses laterally. The more superficial of the medial muscles is semitendinosus muscle, so named because of its long cord-like tendinous insertion. From the ischial tuberosity, the semitendinosus projects medially to insert on the anteromedial surface of the tibia. We identified this insertion point in the previous lesson. Thus, the semitendinosus is the third muscle to insert at the pes anserinus. Deep to the semitendinosus is the semimembranosus muscle. It's named for the result of the larger and more distinct tendon, which lies both medial and lateral to the tendon for semitendinosus. Both of these tendons can be palpated on the medial side of the knee, particularly when the muscles are actively contracting. The semimembranosus projects deep to semitendinosus to insert inferior to the medial condyle of the tibia. The biceps femoris muscle is a lateral muscle in the posterior compartment. As the name implies, it's actually a combination of two separate heads. The long head originates with the semitendinosus and membranosus and thus acts at both the hip and knee joints, whereas the short head acts on the knee joint exclusively. This distinction, as well as the fact that the two heads receive different innervation, means that the short head is not considered part of the hamstring muscle group. Again, we can feel the insertion of this muscle, but this time as a single tendon instead of as two distinct tendons, as in the case on the medial side. The long head runs obliquely from its origin off the ischial tuberosity to insert laterally on the head. The short head takes a more direct route, originating off the posterolateral surface of the distal shaft of the femur. Again, it blends with the long head to insert on the head of the fibula. The function of the hamstring portion of the posterior compartment is to extend the hip while flexing the knee. If the knee extensors act synergistically to resist flexion, the result is pure extension at the hip. In this capacity, the hamstrings are the principal hip extensors in walking. Note, once again, that the short head of biceps femoris can only contribute to knee flexion. It has no function at the hip joint. We've already discussed the vascular supply to the posterior compartment from the previous lesson. Recall the perforating branches off the deep femoral artery. We can see them from the posterior surface now. Innervation to the posterior compartment is from the sciatic nerve. As previously stated, the sciatic nerve is actually a combination of two different nerve segments, the tibial nerve and the common fibular nerve. The tibial portion innervates the hamstring muscle group, while the common fibular portion innervates the short head of biceps femoris exclusively.
Three bones primarily involved with the articulation at the knee. First we have the femur, the tibia, and finally the patella. Note that the fibula, which is located on the lateral surface, does not actually participate in the knee joint itself. It's a non-weight-bearing structure. When we actually look at the articulating surfaces, we can divide them into three separate articulations. First, we have what are called the femorotibial articulations, and in this case, we can actually make a division between medial and lateral femoral tibial articulations. And this is commonly done by orthopedic specialists to divide essentially this knee articulation that we talk about into two separate regions, separated by the intercondylar ridge that we see here. The third articulation is between the anterior articulating surface of the femur and the posterior articulating surface of the patella as well. So that does play a role in the articulation of the knee joint. Note when looking at the articulating surfaces itself that the surfaces are rather incongruent, meaning that they don't line up quite as nicely as we saw, for example, at the sacroiliac joint. The femoral condyles tend to take on a much rounded or a condyloid appearance, but when you look at the tibial condyles, they tend to be much flatter in appearance. So as a result, it may lead to some complications and pressure points. Biomechanically, it seems that we get the best surface contact and stability in the extended position, which is appropriate because this represents the weight-bearing position. If we expand this image out a little bit to look a bit further up on the femur, you'll notice that while the tibial shaft pretty much lies in a completely vertical direction, the femoral shaft actually runs at an oblique angle from lateral to medial as it runs inferiorly. This is because of the weight distribution that comes from the pelvis directed laterally into the proximal region of the femur. This has to be redirected medially once again, hence the oblique orientation of the femoral shaft. So that when you actually look at the knee itself, it should lie pretty much directly underneath the hip joint. And so the overall effect is that the weight distribution from the hip lies directly over the knee, which helps with stability in a standing position. As a result of this, we sometimes talk about what's called the Q angle. And the Q angle is made by drawing a vertical line straight through the tibial shaft and the tibial tuberosity, and a second line from the anterior superior iliac spine to the middle of the patella where it intersects with the vertical line drawn. This creates a small angle that's known as the Q angle and gives us an indication of normal anatomical alignment for the femoral shaft relative to the tibial shaft. This angle ranges between 10 and 15 degrees. It tends to be slightly greater in women due to a slightly wider pelvic girdle. But extremes in the Q angle, either one direction or another, are going to have clinical applications for the individual. Here's the two situations that we're looking at. First, we have what's called a genu varum, also known as bow-leggedness. This is where the femoral shaft lies closer to the vertical, and as a result, we have a decreased Q angle to approximately 5 degrees. As a result of this, that weight distribution from the hip now lies more over the medial condyles of the femur and tibia, and because of the space opening up within the knee joint itself, there's greater pressure put on the medial epicondyle surfaces. So consequently, this is going to create excessive wear and tear on the medial femoral tibial joint aspect, resulting in pain and excessive wear. The opposite situation is called genu valgum, and this is where we have an excessive Q angle greater than 17 degrees is clinically significant. As a result of this, the center of weight distribution now lies directly over top of the lateral condyles of the femur and tibia, and once again opens the joint cavity of the knee up medially, which results in greater pressure distribution on the lateral condyles and more wear and tear on this aspect of the joint. And either one of these situations is going to predispose an individual to osteoarthritis in later life. If you look at the bony architecture of the knee, it's very unstable in that we have a larger joint surface articulating with a smaller joint surface below it. So consequently, this creates some natural instability in just the general construct of the joint. To be able to reinforce the knee, we have a strong joint capsule with some associated reinforcing ligaments that we'll be discussing in depth. Looking at the joint capsule itself, the anterior portion of the joint capsule will actually fuse in to the patella anteriorly. So as we'll see in the next couple of slides, when we look at the internal surface of the joint capsule, the patella is actually continuous with the joint capsule and really makes up that anterior wall and replaces the capsular tissue in that specific region. Posteriorly, once again, we do have some associated ligaments, but the other thing that we'll see with the posterior joint capsule is that it arches over top of and accommodates the popliteus muscle, which we'll be talking about in a later lesson. So we have this tendon of popliteus which runs across to insert on the distal lateral portion of the femur, and as a result the joint capsule actually arches over top of it. Here we see the internal structure of the joint capsule, and again we see how the patella is actually incorporated in. We can also see the synovial cavity, which lines all non-articulating surfaces and is adherent to the articulating surfaces. One of the things that you'll notice is that it extends quite superiorly as a region known as the suprapatellar bursa. This creates some slack in the joint capsule and extension so that the joint capsule will be able to stretch out during flexion without causing damage to the synovial membrane itself. If we look at a transverse cross-section with the femur removed, we can see the attachment point of the synovial membrane around the periphery of the articulating surfaces. One interesting thing to note is you can see in this inferior diagram the lining of the synovial membrane is actually outlined in this faint orange color here. So the synovial membrane actually runs around the cruciate ligaments that we'll be discussing in a period of time. So even though the cruciate ligaments are found intracapsular, they are actually extrasynovial, meaning that they are not actually found within the joint cavity itself. They're within the joint capsule, but not within the joint cavity that's defined by the synovial membrane. It basically runs around to exclude them. So this region here, this anterior portion, and this region on the other side are all part of the actual synovial joint itself. The cruciate ligaments are external to that synovial space. As previously noted, a number of strong ligaments also help to reinforce the unstable nature of the knee joint. We'll start by talking about the intrinsic ligaments, which represent a thickening of the joint capsule itself. First, we can observe the patellar tendon, also known as the quadriceps tendon. So this is a continuation of the quadriceps musculature that runs into the superior border of the patella. This continues down as the patellar ligament. So the same fibers that are blended into the patellar tendon will actually continue across the patella itself. Remember, the patella is a sesamoid bone, so it's floating within the structure. Really, it is the same structure, but anatomists will sometimes use the distinction patellar tendon for where the muscles insert to the superior aspect of the patella, and ligament for where the inferior aspect of the patella is connected to the tibial tuberosity. As the knee is a hinge joint, we also have collateral ligaments to help prevent any abduction or adduction of the leg itself. First, we have the tibial collateral ligament that's found on the medial side and will often be referred to as the medial collateral ligament, or MCL. So this is going to be responsible for resisting abduction of the leg, which is what's called a valgus force or valgus movement of the leg. Also important to note that the distal connection of the tibial collateral ligament partially blends into a structure known as the medial meniscus that we'll be talking about in a period of time and has implications for injury itself. On the lateral side, we have the fibular collateral ligament. This is actually an extracapsular, so it sits outside of the joint capsule proper. But because of its association with the tibial collateral ligament, we include it in the discussion of the intrinsic capsular ligaments for simplicity's sake. Note that the tendon for popliteus actually passes between the fibular collateral ligament and the joint capsule itself. This is going to attach to the head of the fibula and is going to be responsible for preventing adduction of the leg, which we sometimes call a varus stress. Looking at the posterior aspect, we see the arcuate ligament. This is a reinforcement of the joint capsule that projects over top of the popliteus muscle. And additionally, the oblique popliteal ligament, which is a continuation of the tendon of semimembranosus and blends in quite nicely with that. In addition to these intrinsic ligaments of the knee, we also have a number of other structures, particularly muscle tendons, which will help to further reinforce the knee actively. First, observe the iliotibial band. So this is a thickening of the fascia lata on the lateral aspect of the leg, which, as we learned previously, accommodates the gluteus maximus and tensor fascia lata muscle. This represents its inferior insertion point onto a region of the tibia known as Gerdy's tubercle, and demonstrates how contraction of the gluteus maximus and tensor fascia lata can contribute to tension and stabilization of the knee. Some other tendons to take notice of: the tendon for the biceps femoris muscle, the tendon for semimembranosus along the medial aspect, blending into the oblique popliteal ligament, and then this would represent our pes anserinus, which is a combination of sartorius, gracilis, and semitendinosus. If you've paid any attention to anatomical literature over the last year or so, there was a bit of a study that did make some headlines around the world, where a group actually did careful dissection of the lateral collateral ligament that we just identified and have identified this additional, what they call the anterolateral ligament, or the ALL. You will not find this in any textbooks, as this has just been discovered within the past year, and its clinical implications are still being investigated. But the current speculation is that injury to the anterolateral ligament, which was previously unidentified, might explain why some knee injuries might be slower to heal than others where this structure is not actually affected. So probably over the next few years we will see some studies that will specifically look at anterolateral ligament damage to see if it has any implications for rehabilitation and joint stability following surgery. The real interesting note here is that despite the fact that gross anatomy is a fairly stable topic of study, there is the potential for change, and so consequently within the next 5 years or so you will see textbooks include this anterolateral ligament in their discussion of the knee structure. In addition to the intrinsic ligaments that make up the joint capsule, we also have intercapsular ligaments known as the cruciate ligaments. If we think back to when we looked at the elbow, we had a very extensive attachment between the bony segments of the humerus and the ulna in particular, and so consequently that bony architecture prevented any sort of anterior or posterior translocation of one bone relative to the other. When you look at the knee, that doesn't quite exist, so we do have to have something along the lines of collateral ligaments anteriorly and posteriorly to be able to prevent this shift. The problem is we still want to accommodate flexion and extension, and so consequently if we just had a collateral ligament running anterior and posteriorly, those would snap when we try to do any movement of the knee. So the solution for this is to have these oblique running ligaments internal to the joint capsule itself. And these are our cruciate ligaments, so named because they actually crisscross and basically spiral around one another in a clockwise fashion as they go from inferior to superior. First we have the anterior cruciate ligament. It gets its name for its attachment to the tibial portion. So this comes off of the intercondylar eminence of the tibia anteriorly and then projects back to attach to the medial aspect of the lateral condyle. The posterior cruciate ligament comes off the posterior aspect of the tibia and will attach along the lateral aspect of the medial condyle, primarily as we see here. As a result of this orientation, the anterior cruciate ligament, if you look at the fibers and you can kind of see, it's going to prevent anterior translocation of the tibia on the femur, so it's going to prevent the tibia from shifting forward, whereas the posterior cruciate ligament is going to prevent anterior shifting of the femur relative to the tibia. In addition to this, because they wind around each other, they're also going to be able to limit internal rotation to a certain degree. So we see in this situation with internal rotation as being shown in this diagram, these ligaments will intertwine and will actually start to corkscrew around one another, and so medial rotation is very limited to something in the neighborhood of 10 degrees. But if you look at external rotation of the tibia relative to the femur, they actually unwind in this situation, and as a result we get much more external rotation in a flexed knee position to approximately 60 degrees. Although the anterior cruciate is going to be most tensed when the tibia is pushed forward and the posterior when the tibia is pushed backwards, at any given joint angle, there's going to be a certain level of tension within these ligaments. So they're never going to be entirely laxed, and so consequently they are particularly susceptible to movements outside of the normal range, particularly the ACL, at pretty much any joint angle. In addition to ligamentous support, we also have these menisci within the knee. Menisci are fibrocartilaginous discs that lay attached to the tibia. If you remember when we started talking about the knee, I talked about the incongruency between the femur and the tibia. These fibrocartilaginous discs basically fit the contour of both the tibia, so they're flat on the inferior surface, but they have a wedge-shaped design, so the superior surface actually is curved and projects up to meet and accommodate the femur to increase surface area contact between the menisci and the femur. Being fibrocartilaginous discs, they also are somewhat cushiony, so they serve as shock absorption and decrease the amount of force between the tibia and the femur to prevent wear and tear on the hyaline cartilage surfaces of the two bones. First, we have the medial meniscus. This is typically described as being more of a C-shaped orientation. You can see in this diagram over here that it is anchored at two very specific spots in the intercondylar ridge region of the tibia. But note that when we look at the outline, once again, of the synovial membrane, that unlike the cruciate ligaments, the attachment points for the menisci are actually within the synovial cavity, not external to it. So these are actually right within the synovial cavity and bathed with synovial fluid to directly participate with that articulation. The lateral meniscus is located on the lateral aspect. Once again, we can see its attachment points, which are a little bit more centered within the tibial plateau region. One other important distinct difference to note is that in addition to these anchoring points, we also have what are called coronary ligaments along the periphery of both menisci that help to anchor them to the tibia. They're much more extensive in the medial meniscus, whereas the lateral meniscus tends to have a little bit more give and a little bit more maneuverability to it. Finally, as mentioned before, we have the tibial or medial collateral ligament, and you can see how that medial collateral ligament will actually partially insert into the medial meniscus from this diagrammatic view. Typical plain film x-ray looking at the knee joint itself. You see the outline of the femur, the lateral and medial epicondyles, the lateral and medial condylar surfaces. You can even see a little bit of the outline of the condylate structure of the condyle itself. Tibial plateau, get a good idea here of how this is flat relative to the curved condyles of the femur. We can see the medial and lateral intercondylar tubercles as part of the intercondylar eminence. The fibula, how it's associated with the lateral aspect of the tibia. And faintly, we're also able to identify the patella as the light region just proximal to the femur itself. This is a sagittal MRI taken at different regions within the knee itself, and so what we could see is the ACL, characterized by its anterior attachment point to the tibia and posterior attachment point to the femur. And the additional diagram, you can see the posterior cruciate ligament and how it takes a bit more of a tortuous route to be able to reach its target. A little bit of the PCL also shows up in this view here because of their twisting and intertwining, but remember, we're looking at a two-dimensional view, so the PCL runs out of the plane of the MRI image at this point, and this is really just focusing on the ACL. Take a moment to see how these different intrinsic and intercapsular ligaments assist with knee stability. First, if we take a look at the collateral ligaments, you'll notice that in an extended position, the ligaments tend to be taut, whereas in a flexed position, there's a little bit more looseness within these ligaments. So this is part of the reason why when your knee is in a flexed position, you have a little bit of rotation permissible, but in the extended position, the knee tends to be locked out, which we'll describe a little bit more as well later. So that's what provides stability to the knee when it is fully extended, and it's assisted by a very strong posterior joint capsule as well. Something else to mention regarding the knee joint stability, we mentioned in the previous slide with the cruciate ligaments that they minimize medial rotation of the tibia on the femur. If you look at this diagram, what you'll notice is the orientation. The fibers here run at a slightly oblique angle for both the medial and lateral collateral ligaments, such that with the medial rotation where the cruciates get tight, these tend to become a little bit looser. But similar to what we saw at the hip joint, because of the slight oblique orientation, lateral rotation creates tautness within the collaterals. So it's the collaterals that actually primarily resist lateral rotation of the tibia on the femur, particularly in a locked knee position. This creates an interesting phenomenon. When you actually look at the contours of the tibia and the femur, the femoral condyles have a slightly different architecture. The medial condyle tends to be smaller and have a much more pronounced curvature. As a result of these differences, when we go from a flexed to extended position, it does tend to produce lateral rotation of the tibia on the femur in the last few degrees of knee extension. As a result of this, we see tautness within the collateral ligament similar to what we saw at the hip in extension. This tautness tends to pull the tibia closer to the femur and creates this locked out appearance of the joint itself, and sometimes referred to as the screw home mechanism to describe how the knee will actually lock out. This is important to normal posture in a standing position. Because we're able to lock out our knees, we effectively create a rigid bridge between the femur and tibia that requires very little muscular contraction to maintain. A small little experiment you can do for yourself is to try standing with your knees completely locked out and be able to hold that posture for several minutes on end for a long period of time. Now try bending your knees about 10 degrees or so and see how long you can maintain that posture. With that 10 degrees of bending, you've actually unlocked the knee itself. As a result, it requires a lot more muscular contraction to actually maintain the knee in that nearly completely extended position. So results in muscular fatigue, and the locked out position is just more energy efficient for us over time. One final note as a prelude to our next lesson is we will be talking about a muscle called popliteus, which runs from lateral to medial, from the tibia to the femur, and this muscle is what's responsible for initially unlocking the knee from that locked out position. So something to keep in mind for when we talk about it in the next lesson. Here we have a video from the 2013 NFC Conference Championship game. You can see Navarro Bowman, number 53 for the 49ers here. As you can tell from this video, he gets hit from the outside of the leg, what we typically refer to as a valgus stress on the knee, which causes the knee to open up on the medial aspect. So the medial collateral ligament, which normally resists this valgus force, ends up being torn in the situation. And with further stress on the knee, remember what I said, that the cruciates are always under a slight degree of tension, and so consequently the force was enough that it also resulted in rupture of the anterior cruciate ligament. There's actually a variety of different injuries that can occur to the knee and a variety of different ligaments that can be torn in one fashion or another, either in an isolated or in combined fashions. It's a little bit too lengthy and complex a discussion to have for the podcast. We will be discussing it further in class, but there is one specific injury that I would like to bring to your attention because of recent debate. This is called the unhappy triad. The unhappy triad is a combination of three separate injuries that typically happens with a valgus stress on the knee and external rotation of the tibia when the foot is in a planted position, very similar to what we actually saw in the previous video. Typically what will happen with the unhappy triad is you will get tearing within the medial collateral ligament and tearing of the anterior cruciate ligament, and that's what Navarro Bowman actually suffered. The third part of the unhappy triad is tearing of the meniscus, and this is where the debate comes in. If you look at the classical literature, it talks about it being the medial meniscus, and this is thought to be due to the medial collateral ligament coming in and attaching to this point. Recent studies, however, have shown that it's actually a bit of a mixed bag, that either menisci can tear, and it's actually the lateral meniscus which seems to tear more in the unhappy triad situation in an acute knee injury. And it's believed to be because of this valgus stress that's being put on the knee creates a compression force between the lateral condyles of the femur and tibia, which can trap up the lateral meniscus and actually cause its tearing. So you have to be careful of the sorts of information that you go to, and it's still commonly taught in classrooms, and it is a huge issue of debate that it's classically thought of as the medial meniscus, and it's still sometimes taught this way. But based on the most recent research, it does seem that it is in fact more often the lateral meniscus, and it will be taught more commonly this way as further research develops. The medial meniscus, though, is the one that is most often torn. That is the case, but typically we see it being torn in normal pivoting and shifting, particularly with compromised ACL knee, where the ACL has ruptured from a previous injury. It creates a little bit more instability and rocking back and forth of the femur on the tibia, which creates grinding. The lateral meniscus is a bit more mobile, so that excessive rotation and grinding tends to not affect it as much, whereas the medial meniscus is greatly affected because it is less mobile. And so consequently, from pivotal motions, we typically see the medial meniscus torn about 7 times out of 10. But with the acute unhappy triad situation where the medial collateral ligament, ACL, and meniscus is torn all at the same time, it's usually 6 times out of 10 you're going to see the lateral meniscus being the fibrocartilaginous pad that's actually torn. I'll finish off with something that many of you are likely going to see on your bodies in lab if you actually open up the knee joint, and that's excessive wear and tear that we see on the articulating surfaces of both the femur and the tibia, but particularly the femur because it doesn't have the fibrocartilaginous pad as closely associated with it. This is typically called osteoarthritis. It represents a degeneration in the hyaline cartilage characterized by wearing away of the cartilage and exposure of the underlying bone. Another thing that you might observe in knees, particularly if there's been a history of injuries or a history of excessive wear, is the bone will try to remodel itself outside of the hyaline cartilage surface, and that results in osteophyte formation, as we can see here, which is more commonly known as bone spurs. So something to be aware of and to take a look at. It will give you a good indication as to the conditions of the knees and an idea of whether the person was in discomfort and how they were able to get along. That concludes this podcast on the gluteal region, posterior thigh and knee. In the next podcast, we'll be moving into the leg itself, the more commonly called the lower leg. We'll be looking at the anterior and lateral compartments. We'll also be looking at the region in the back of the knee known as the popliteal fossa, as well as looking at the bony architecture of the foot and the ankle and what we call the subtalar joints. Until that point, this has been Dr. Stuart Ingalls. Enjoy the rest